Well, certainly appreciate you folks staying for what I hope is going to be a good, exciting afternoon. We're on the home stretch here, 3 more hours to go. Our first speaker is Dr. Martini. Dr. Martini is a professor of pediatrics and psychiatry in the School of Medicine at the University of Utah. He's also chief of the Division of Behavioral Health in the Department of Pediatrics and also director of Child and Adolescent Psychiatry at Primary Children's. As I reviewed his history, it seemed like everywhere this guy went, he became the director of the program. So he started out on the East Coast in undergraduate at Johns Hopkins, and then went a little bit west to the University of Nebraska College of Medicine. I guess that's not Creighton. It's a different school in Omaha, Nebraska. And then headed back east and did a pediatric residency, a psych residency, and a child psych residency at the Western Psychiatric Institute and Clinic and at the University of Pittsburgh. After graduating, he then became, as I indicated, program director for psychiatric consultation for a liaison service at Children's Hospital in Pittsburgh. And he remained in that position for about 7 years, then decided to head west and headed to Chicago. And there he served as director of intake, consultation and emergency services, co-director of the Medical Psychology Psychiatric Outpatient Services Program and Department of Child and Adolescent Psychiatry. This was at Children's Memorial Hospital in Chicago. It sounds to me like he was recruited out here to the West 2 years ago, arrived at Primary Children's, and has the position I've indicated. I'll read his special interests, special expertise in identification and treatment of psychiatric disorders in medically ill children and adolescents, his particular interest in neuropsychiatry and the effects of insults on brain behavior, working with young patients following mild head trauma or who are suffering from symptoms of post-traumatic stress disorder. Also worked closely with the intensive care unit studying delirium in young patients. So it's with pleasure that I welcome Dr. Martini for his presentation on the prevention and depression in at-risk adolescents. Please welcome Dr. Martini.
Thank you for that very kind introduction. It's really a pleasure to be here. We're going to talk a little bit about depression and review a bit of etiology, also diagnostics, and some treatment as well. Let me talk a little bit about the epidemiology of depression, and we're going to focus mostly on adolescents, children and adolescents. That basically, when you're looking at the population, about 2% of children and between 4 to 8% of adolescents suffer from symptoms of major depression. And the male to female ratio is about 1-to-1 in childhood, but then it changes in adolescence and becomes more 1-to-2, much more prevalent in female patients than in male. The cumulative incidence is about 20%, so about 20% of all kids by the time they're 18 have had some episodes of major depression. Dysthymic disorder, which is kind of a lower grade depression, kind of a chronic depression that persists for longer periods of time, is evident in about 0.6% to 1.7% of children, and as many as 8% of adolescents. The clinical description of major depression I want to talk a little bit about to give you an idea of what we're talking about. It's a disorder that persists for about 2 weeks with either depressed or irritable mood and/or loss of interest and pleasure. There are a variety of additional symptoms that we look for in depression: suicidal ideation or attempts, increased or decreased appetite with weight change, sleep continuity problems, decreased concentration, decreased energy, lower self-esteem, exaggerated feelings of sadness or guilt. Now, in children, quite often we see subsyndromal presentations of a variety of psychiatric disorders, and that's also true in depression. In about 5 to 10% of patients, they will have symptoms that don't exactly meet diagnostic criteria, but nevertheless we're concerned about them. There's some psychosocial impairment in these kids. They quite often have family histories of depression, which is an important factor in the history of these cases. And even though they're subsyndromal, they also have an increased risk for suicidal behavior. They're also at increased risk if you have subsyndromal or minor symptoms of depression for eventually developing major depression. Now, there are also exclusionary criteria. So when we talk about these patients and we consider the diagnosis, there are things we want to look at that can certainly complicate the presentation. And one of them is substance abuse. It's very difficult to make a diagnosis of depression if you're dealing with a patient who's actively using or abusing substances. If they're on medications, because there's a variety of medications, like steroids, for example, that when a patient is on steroids, they can have a great deal of mood lability, including episodes of depression, particularly when they're being withdrawn from steroids. And so you need to get that history before making the diagnosis. There are a variety of comorbid psychiatric diagnoses that accompany depression and that can also be mistaken for depression, particularly a variety of anxiety disorders. And sometimes patients experience post-traumatic stress disorders and can have some of these same symptoms. Bereavement. We certainly want to separate out patients who have suffered a significant loss and are sad and are withdrawn and maybe temporarily experience sleep continuity problems. And it's important for us to separate out those patients from patients who are really experiencing a significant bout of major depression. And then, of course, medical illness. There are a variety of medical illnesses that can precipitate mood problems, endocrinologic disorders, anything that affects the central nervous system can have psychiatric consequences, and among those consequences are symptoms of depression. How do you compare pediatric patients with adult patients? I think basically what you want to look at, and what we look at in evaluating children, are the differences in physical, emotional, cognitive, and social developmental levels. And what that does is it affects the patient's ability to directly communicate symptoms. And I think it's one of the reasons why with children we often look for multiple sources of information. You're not just getting information from the patient, but you're also getting information from the parent, from the teacher, from peers, from contacts, because you need to corroborate that. At times it's very difficult for children to go into great detail about their symptoms of depression. Also, the other thing about children is that they don't present typically as being sad or tearful. They most often present as angry, irritable, labile, with low frustration tolerance, temper tantrums. That's how children most often present. They will have somatic complaints, recurrent abdominal pain, recurrent headache. So, for example, before I came down here, I saw a patient on the consultation liaison service at primary that has recurrent debilitating headaches. And she suffered from depression for probably the last year or two. And the concern is that there are stressors in school that are exacerbating her depression, and that presentation is now in the form of somatic symptoms. And then social withdrawal, where these children will not be as active socially as they typically are, don't see as many peers, and aren't as interested in doing things. They don't have very many delusions. And delusions, are those kind of thoughts that people have that only they believe and are otherwise nobody else believes. And quite often these delusions are delusions that support the depression. So nobody likes me, nobody cares about me, I'm stupid, I'm ugly, people are out to get me, all those kinds of thoughts that tend to reinforce the depressed mood. There's also fewer suicide attempts in kids than adults. And some of that, I think, it may be developmental. I take all suicidal behavior, all suicidal ideation very seriously, regardless of how old the patient is. But I think the difference is developmental, that children can't figure out how to make it work, can't figure out a plan, can't actually physically do things that are as dangerous as adults. I talked a little bit about comorbidity. It's important to think about additional psychiatric disorders when diagnosing depression in adolescents. About 40 to 90% of depressed pediatric patients have additional psychiatric disorders. And among those are anxiety disorders. There's a tremendous amount of comorbidity with generalized anxiety, obsessive compulsive disorders, specific fears and phobias, post-traumatic stress disorders, disruptive behavior disorders. And those are the kind of kids that have conduct problems, break rules, interfere with the rights of others. Attention deficit hyperactivity disorders. I think we're sort of familiar with that diagnosis. What happens typically with those kids in leading to depression is that they're not diagnosed for a long period of time. They continue to have problems in class. They're ostracized by peers. They're constantly redirected by teachers. The parents are constantly going to the school for one problem and another. And after a while, after several years of this, they begin to internalize a lot of that stuff and begin to think of themselves as not that good, not that well liked. And those, I think, kind of thoughts and kind of feelings can reinforce a depressed mood. And of course, substance abuse. There are a variety of substances that can lead to depression in adolescence. One of the things that's interesting is of all those disorders that I listed, the two that persist after the depression resolves are conduct disorders, significant behavior problems, and substance abuse. So you can treat the depression quite often with anxiety disorders, with patients who are irritable and disruptive, and those behaviors will change. But if they're abusers, if they have serious, and when we say conduct problems, you cross a line from being oppositional and saying no a lot to someone who is truant, someone who gets suspended from school, who has been picked up by the police, who is physically assaulted, who steals, lies. Those are conduct problems. And you can treat the depression and those problems will still persist. There's also a variety of other diagnoses that we need to include in the differential. And there are a variety of medical illnesses that can lead to symptoms of depression. Hypothyroidism, anemia, malignancies, autoimmune disorders, chronic fatigue. There are also, and I alluded to this earlier, a variety of medications that can cause depressions. Stimulants. Sometimes when we see kids who are on too high a dose of stimulants, they're kind of sitting there and they're kind of dull and they're sort of not responsive. They may look depressed to people who otherwise interact with them. Corticosteroids, I mentioned, also contraceptives. And even though OBGYNs will constantly talk to me about the fact that depot contraceptives do not lead to mood problems, I've taken care of 3 or 4 young women who have had serious problems with contraceptives for extended periods of time and have required medications in order to treat their depression. I think what you try to do in differentiating out some of these diagnoses is you look at the course of the illness. You relate the onset of the medical problem with the onset of the symptoms. And if you can't, if there is a history of mood problems that predates these other factors, then the chance that they're having an underlying depressive disorder is higher. What's the clinical course of depression typically? Depression usually lasts about 8 months for patients that are referred in for treatment. Now, of course, we see a biased population because by the time they're referred to us, they typically see you. They typically see their physicians first, or they go to their clergy. But by the time they get to us, there's a level of disability that indicates a higher severity of symptoms. Typically, in a community sample, episodes of depression last about 1 to 2 months. There's a fairly high recurrence rate because the way to think about mood disorders is that in general they're recurrent. They occur, they go away, they come back. And the recurrence rate in adolescents is about 20 to 60% if they have not been depressed for about 1 to 2 years. If you wait 5 years, about 70% of patients that have had an episode of depression will have a recurrence. There's risk factors for recurrence. If you're dealing with a patient that has a strong family history of mood disorders, they're at a higher risk. Also, if you have a patient whose symptoms are really severe and they go on to develop bipolar disorder, and I know you guys have had a lecture about that yesterday, talk about that yesterday, they tend to have more severe behavior problems. They tend to have more difficult mood disorder as far as treatment goes, and they are more likely to get involved in substance abuse. And the thought, I think, around substance use is that they're trying to medicate themselves. Just anecdotally, I think among adolescents that I've seen that have suffered from bipolar disorder, there's high rates of the use of marijuana. I think marijuana tends to calm them down. They still remain somewhat social, but they are less likely to get into trouble. Now, when we're looking at depression in adolescence, what are the things we look at that will give us some idea of the outcome being not as good, somewhat poor? If it's severe, the symptoms are really debilitating. The patient has suicidal behavior, is doing poorly in school, is not doing well socially, has a degree of helplessness and hopelessness. If it's chronic, meaning that it's persistent, it doesn't come and go, it's there all the time. And there are some patients that I've treated that have been chronically depressed for 1 to 2 years straight. Comorbidity, meaning that they have some of those disorders that we talked about. When you interview the child, if they talk about a sense of hopelessness, nothing's going to get better, relationships with their peers is not going to get better, they're not going to do any better in school, their life really is going nowhere. If they have a negative cognitive style, and this is something that we look to also around therapy. When I talk about a negative cognitive style, that's the kind of person who says, I have really nothing significant to offer, nobody likes me, I've done poorly on that test, I'm bad looking. Everything is a negative perception of what's going on in their life. And the reason why that's related to treatment is because one of the treatments I'm going to talk about, cognitive therapy, tends to correct that kind of thinking. But you can imagine that if that's the persistent cognitive style that you have, it tends to reinforce depression. Family stress and conflict, including abuse. This, I think, is very important, and it's becoming increasingly important. I was at a meeting last week down in New Orleans, the Society of Professors of Child and Adolescent Psychiatry, and there were presentations there about the interactions between genes and behavior, genes and environment, excuse me. And they've actually begun to identify changes in gene structure that results from exposure to chronic, stressful, and conflicted environments. So things that we have suspected, that children who grow up in highly conflicted, intense environments tend to be at greater risk for emotional distress. It may not only be social, it may also be biological. Also lower socioeconomic status, and there are a number of factors that go along with this. People who are lower socioeconomic status tend to live in crowded conditions, for example. And we know that crowded conditions, even when in animal studies, tend to breed higher levels of irritability and aggression. We know that lower socioeconomic status tend to be single parents. There's less supervision. There's less structure in their lives. That these patients are more susceptible to mood problems. Talk a little bit about complications of depression. Suicidal behavior, I'm going to go into more detail about that. Substance use, talked a bit about that. Early pregnancy, patients that have problems with mood disorders and depression tend to be sexually active earlier. You could hypothesize about why that's true, but they tend to get pregnant earlier. Poor academic performance because they have a lack of energy and a lack of interest. They tend to miss a lot of school. Physical illness, I mean, one of the things that's interesting about diagnosing depression is that somatic complaints are part of the differential diagnosis. They're one of the symptoms that you look for. And so, for example, with a patient that I saw today, differentiating out the somatic complaints and the physical illness from depression is one of the challenges in diagnosis. They tend to have more problems legally. And again, that's related quite often to the oppositional problems in the conduct disorder. And they are exposed to more negative life events. And some of that is because depression runs in families. And so it's not unusual for a depressed child to have one or both parents with depression, to have depression in the family, and as a result, there's varying levels of family dysfunction. So what are the risks for suicide? Because I think of all the factors and all of the complications that we look for with major depression, suicide is, of course, the most emergent. And when you're looking at suicidal patients, the risk factor that is most prevalent and that is the biggest warning sign is major depression and poorly controlled major depression. These patients have a history of suicide attempts, so we ask about that, about frequency, about how close it is to the current event. If they have multiple psychiatric diagnoses beyond major depression, the way to think about suicides are most suicides are impulsive and aggressive acts. It's rare that patients kind of plan it, that they lay out, that they things, that they write notes, that they give things away. Most suicides, particularly among adolescents, are impulsive. And so if you're dealing with a kid that has ADHD, that has conduct problems, that's aggressive, has a history of being suspended and getting in trouble in school, and they have suicidal behavior, you have to be very, very concerned about that. You look at the availability of lethal agents, drugs, weapons. One of the things that we talk about quite often with families, do you have guns in the home and can you get rid of them? And sometimes it's a tough negotiation because families want to hang on to the guns that they have in their homes. But sometimes communities can develop programs where families can hand in their weapons temporarily. In the city of Chicago, the police force developed a program where families could hand in their guns, no questions asked. So if they weren't registered, if they didn't have a license, if there were legal issues associated with the gun, there were no questions asked. If there was a note from a psychiatrist saying that it was for the safety of their child. Exposure to negative life events, I talked a little bit about that, and family history of suicide. I think just like anything else, children really pick up in their family on ways of solving problems. And if they see that there's a pattern within a family of self-injury and self-destruction, that they themselves see this as an option. Similarly, when we see patterns of somatic disorders, recurrent headaches, recurrent stomach pains, that the children adopt this as a means of communicating distress. I talked a little bit about the integration of genetic and environmental factors and how that's becoming more prevalent. The strongest predictor for depression is a family history. Some of these things are mediated by the presence of loss and trauma. So you look at a population, 2 kids with comparable family histories of mood disorder. If you have a child that experiences a great deal of loss, a great deal of trauma in their lives, that child is at greater risk for developing depression. And again, the negative attributional style is particularly important. Now, when we make the diagnosis of depression, when we're actually interviewing the patient and talking to the parent, what do we look for? Generally, you need to have evidence of sad mood and irritability and anhedonia. Those are the primary symptoms of the disorder in a pediatric population. And it's got to be there most of the time. It can't be present in one environment and not be present in another. So if a child experiences these symptoms at home, but is otherwise functioning well in school, I'm less concerned about a diagnosis of major depression, and I'm more concerned about the dynamics in the home. There should be some effect on psychosocial functioning. Peer relationships, family relationships, functioning in school. I go back to school quite often because I really believe that school is the work of childhood. With adult patients, when you evaluate how they're doing and their quality of life, you look at employment, you look at how well they're doing on their job, whether they're getting along with people, getting along with their supervisors, moving along, and school is like that. What is their attendance like? Are they getting along with their peers? Are they getting along with teachers? Are they completing assignments? Are they passing? Also, I think, are the symptoms not what's expected from the child based on chronological age and developmental level? And what I'm referring to there is mostly regression. That mood disorder, kids tend to regress a good bit, and they'll get more dependent. They might even lose developmental skills that they've gained. And so it's not unusual for a young child, perhaps who's 7, 8, or 9, for example, to become anuretic as one of their symptoms of mood disorder. You also want to consider a variety of ethnic, cultural, and religious characteristics when talking about mood disorder. I think I learned a lot about that when I was in Chicago because it's such a multi-ethnic city. But there are a lot of biases around psychiatric disorder in a variety of ethnic communities with a variety of cultures. And you need to be sensitive to that in the way it's discussed and the way it's presented. There have been families that I've worked with who viewed the child, particularly, in some instances that I can think of off the top of my head, young women who were now less desirable for marriage, who were somehow an embarrassment to the family because they saw a psychiatrist, because they required a psychiatric hospitalization. I think it's important in the assessment to consider these things. You need to interview the patient individually. I think if you just interview the child alone, if you just interview the child with the parent, you're going to miss probably about 25 to 30% of the data that you need. It's really true that children, there's a lot of these things that are internal, just like us. That we have thoughts, if we're having problems, if we're having challenges, we don't share them with everybody. We may not even share them with significant people in our lives. And children are the same way. Quite often they won't share these things because they're afraid of the parental reaction. They're afraid that they're going to upset their parents should they be completely honest about what they're thinking and feeling. I talked a little bit about multiple sources of information and how important that is. The other thing to remember is that parent reports can often be influenced by their own psychopathology. And this has been shown time and time again in a variety of studies. Depressed mothers report more depression in their kids. And so it's very important to understand what's going on with the parents, how they are doing and how they're functioning when reviewing the data that they provide on their children. Assessing suicidal behavior. When we're doing the interview and we're trying to evaluate a child for relative risk, what are we doing? We're first of all identifying current stressors. Because like I said before, most suicidal behavior is it's impulsive, it's abrupt. The adolescent experiences a narcissistic injury, feels that their life isn't worth living, and they do something dramatic. In the vast majority of cases, because one of the things that I've done is I cover the emergency room at all of these children's hospitals and currently do that at primary. So suicidal behavior and getting some sense of what goes on is a big part of consultation liaison work. So a child, what's going on at that time, at that day, right before they came in. And sometimes what I talk to trainees about is actually doing some kind of police work. I actually ask them, so like, tell me what happened today. You know, what happened immediately before you took those pills? What happened today in school? They themselves initially will say, well, nothing happened today. Well, just tell me what's going on. Well, you know, went to school, saw a girlfriend, she accused me of stealing her boyfriend, and she beat me up in the bathroom. Do you think that has anything to do with what happened tonight? Well, I guess it could. And I think that in that process, that's how you really uncover some of the motivations behind the behavior. And with that, you want to determine their subjective experience, particularly the idea about hopelessness, impulsivity, increased anxiety. You also want to look for protective factors. Clearly, religious beliefs is a protective factor, and there are a variety of studies that have shown that religious taboos against suicide are very protective for adolescents. You also want to have them talk about the family. If they say, well, you know, I would never kill myself because my mother would be crushed and I would never do anything to hurt her. That's a positive statement. And also hope for the future. What are their plans? If I'm evaluating a child who has made a suicide attempt and I talk about what their interests are and where they are in school and what they want to do after high school, and they have elaborate plans and they're fairly enthusiastic about it, even after they've made a suicide attempt, I feel better about that particular case. You want to also ask during the evaluation about how they feel right at that moment. When you're talking with them in that conversation, do they still feel suicidal? Because if you interview a patient and they say that yes, right now in this conversation, they wish that they were dead and that they're going to try to kill themselves again, they need to go into the hospital. We also go over the history of suicidal behavior and the severity of the attempts. So you can have patients who do everything from scratch their wrist with a paper clip to patients who have taken large overdoses of medications, clearly understanding that the medications will do them harm. All the comorbid psychiatric conditions that increase dangerousness. I think that what you want to do is, one of the things that's happening now in the adolescent population is an increase in self-injurious behavior. And it's important to separate out repeated self-injurious behavior from suicidal behavior. Patients will cut themselves repeatedly, they'll scratch themselves repeatedly in an attempt to relieve anger and relieve distress. It's pathologic, it's problematic, but it's not suicidal. The thing that's dangerous about it, of course, is that these patients may accidentally do something serious. So you have a patient who is superficially cutting themselves, the pain helps them calm down, and then accidentally they nick the artery and then they've got a serious problem. The thing about homicidal behavior, which is the other psychiatric emergency that we deal with in these kids, they follow the same pattern, the same sort of risk factors, the same sort of personal history. Looking at environmental factors. As I said, these are increasingly considered important in the adolescent's presentation. You want to make sure that this child has been or not been exposed to physical or sexual abuse. That dramatically increases the risk of mood disorders and suicidal behavior. You want to get a sense of what the level of conflict is within the family. Not only within the family, between the parents and the siblings, but also outside the family. Are they fighting with the law? Are they fighting with the school? Are they fighting with employers? Are they fighting with their neighbors? Neglect. Is this patient alone most of the time? Do parents go with them and understand what's going on in school? Are they participating in any aspects of their lives? Talked a little bit about poor neighborhoods and lower socioeconomic status and overcrowding. How exposed are they to violence within the family? Also in entertainment, in games. How preoccupied are they? There's a fair amount of literature now, particularly in vulnerable children and adolescents, that repeated exposure to violent movies, violent themes on TV, and I think they're doing a lot of study about violent games can escalate adverse behavior in the patient. You want to look at the peer group. The peer group for adolescents is extremely important. Not as important as parents, but pretty close. And no matter what you do with that adolescent, if you're trying to change the behavior, one of the key things that you're looking at is who are they hanging around with, and do we need to make a change in that to change behavior. There is a strong relationship between depression and levels of conflict in a variety of settings, and so it's important to look at that and consider it. So let me talk a little bit about depression and the treatment of depression. I think initially what you want to do with these patients is you want to acutely achieve control and some symptomatic remission. You don't want them to be agitated. You don't want them to get into trouble. You certainly don't want them to be suicidal. And so you want to manage that behavior as quickly as you can, and you want to relieve those symptoms. You want to then, in continued treatment, solidify the care. So make sure that the patient is on a medication or in a therapy that they feel comfortable with and that they're making progress with, and try to minimize the likelihood that that patient is going to relapse, is going to experience more problems. Clearly, maintenance treatment prevents relapses over a longer period of time in more severe and recurrent cases. This is something that has clearly been demonstrated in the adult population, and increasingly in studies of adolescents is also true. You need to follow these kids for a good long time. And what I'll do for a patient that's on meds, for example, is if they've been stable for 6 to 12 months, I will give them a period off of medications. And even if they continue in therapy, to see whether there is a recurrence of their symptoms. And it gives me an idea of just how severe the symptoms are and how long I need to keep them on medications. The environment. What do we do about that for the depressed adolescent? Psychoeducation. It's really very important that family members and the patient understand as much as they can about what depression is, how serious the problem is, how recurrent it is. You also want to sit down with them and talk about this particular case. What are the causes of it? Is there a strong family history? Are there environmental factors that play a particularly important role in the etiology of the disorder? What are the predominant symptoms that the patient has? You don't want to necessarily reveal or reveal a lot of secrets that the patient may have or lose the patient's confidence, but you need to give the parents some sense of what symptoms they're looking for as signs of relapse or exacerbation. What is the typical course? You want to let them know that it comes and goes, that it isn't persistent. And the fact that the patient may be asymptomatic for a while doesn't necessarily mean that they're cured. You want to talk about the treatments and how important it is to couple medication and therapy, and how important it is for them to participate in this process, and all the risks that are associated with treatment. You also want to let the family know that this is a recurrent chronic illness, that mood disorder is something that their adolescent is going to struggle with for a very long time, and that it's important, therefore, not only for them to recognize the symptoms, but even more importantly, it's important for the patient to recognize the symptoms in themselves. I've had patients who had mood disorder. I had a patient who had a mood problem every holiday season. And he was a teenager and then eventually went to college locally. And he came to me at the beginning of every November, and he said, I'm starting to feel symptomatic again. I think I need to go back on medications. And he would go on meds through the end of January, beginning of February, and then we would take him off. And he was very, very good at identifying all the risk factors. Family involvement, I think, is really, really crucial. You want them to be part of the treatment contract. I know that there are some therapists who see the patient alone, who see the child alone, and don't interact with the family. Myself, I don't know how that works. My own bias is to involve the family as much as I can in the process, as much as the patient feels comfortable. My feeling is that I spend maybe an hour a week, an hour every 2 weeks, sometimes an hour every month with the patient. But the parents are with this adolescent constantly. And so it's important for them to know, I think, what's going on and to be involved in the treatment. Also to let me know how they think the child's doing. I think that it's also important for the school to understand what's going on with the patient. Patients and families are sometimes reluctant to let the schools know that, they're being treated for a psychiatric disorder. I mean, I understand that there's a stigma that's still associated with that. However, there are modifications that the schools can make for patients that are depressed. They can make accommodations in workload, in schedule, and can do that with recommendations from the physician as well as from the psychiatrist as well as from the therapist. Patients may qualify for disability under IDEA. They're eligible for school-based services, for therapy in the schools, and arrangements can be made within the schools for these kids to facilitate learning. I'm mentioning supportive psychotherapy because this is a form of psychotherapy that is, I think, fairly straightforward and I think can be done in a variety of settings, including in the medical office. I think increasingly it's important, I think, for mental health professionals to work collaboratively with medical professionals, particularly with primary care providers, in making sure that patients and children and adolescents with psychiatric disorders, mental health problems are identified. It's also possible, I think, and one of the things that we're working on, I do work with the American Academy of Child and Adolescent Psychiatry. We're trying to encourage primary care clinicians to begin to pick up some responsibility for identifying, assessing, even beginning some basic treatments with these kids. And one of the interventions that can be done in a practice, not just by the primary care clinician, but by a variety of ancillary staff, is supportive psychotherapy. It is generally for uncomplicated or brief forms of depression with milder forms of psychosocial impairment, no evidence of suicidal behavior, no evidence of psychosis. And what you're doing is you're basically providing education and support. You're correcting those cognitive misperceptions that they have, and you're supporting them. So you're reinforcing those things that are positive about them. It's also an opportunity to do some case management, to identify with the patient stressors at home and in school, to elicit some support from the family in the work that you're doing. The recommendation is that if you do supportive psychotherapy and you do this for a period of 6 to 8 weeks, and the patient continues to be symptomatic, is not really benefiting from sort of cognitive restructuring and the support that you provide, that it's a good idea to then refer them on to a mental health professional. You can limit this to a single visit, or it can be part of your regular outpatient contacts. The idea in supportive psychotherapy is to remain positive, to offer advice, to offer reassurance. I think that you want to concentrate on the here and now, not on an anticipated problem, but you want to provide relief from the emotions that are accompanying that current problem. It's a conversational style. It's not a clinical style. The purpose is to contain the patient's anxiety and upset in a way that allows her to continue to function. And again, education, encouragement, support to solve problems. You don't want to get into conflicts. Talk about problematic relationships with parents, problematic relationships with siblings. You don't want to talk about long-standing feelings, jealousies toward younger sisters, or anger, long-standing anger that they've had at a divorced non-custodial parent. Those are the sorts of things that are involved in more complicated forms of therapy. But in a practice in supportive therapy, you can, I think, build up the patient's ability to cope with the current situation that they're facing, reinforce their positive accomplishments, the positive things that they have going, and their ongoing success in your contact. I think that there are also a variety of supportive interventions that nursing staff can do during a hospitalization. If you are treating a patient in hospital that has, you're concerned that the adolescent is suffering from depression, again, I think that you want to focus on goals, on coping with the problems, on coping with the disease that they have. Speaking about patients that have concurrent medical problems and psychiatric problems, because what we know is that about 30% of all patients with chronic medical disorder have some form of psychiatric illness. And the most prevalent diagnoses are depression and anxiety. The idea also is you want to enhance compliance. We know, for example, that improved compliance and therapeutic alliance kind of go together. And if there are ways for your nursing staff, for your staff, for you to improve that connection with the patient, I think that better compliance can result. Also, in the long run, it may decrease the incidence of depression. So part of this is facilitating emotional expression, psychoeducation, practical advice, and what they call promoting a life narrative. I guess that's sort of a bit of a psychobabble, but basically what you want to do is you want to get the patient talking a little bit about their situation and how they're feeling at that time. Now, for mental health professionals, there's a variety of psychotherapeutic interventions that we use with depression. I alluded before to cognitive behavioral therapy. This is where you try to correct those negative cognitions that are reinforcing the mood disorder. And the behavioral component is you actually want to encourage those people, those significant others that are working with the adolescent to reinforce positive behaviors, to reward positive behaviors, to encourage them to make progress. So if a child is not attending school on a regular basis because they're struggling with mood problems, every step that they take in a gradual introduction is reinforced, is praised by the parent, is praised by the school, is praised by the therapist, because you really do accomplish much more with sugar than with vinegar. And the thing I say to parents is pay attention to what you want to see and ignore what you don't as much as you possibly can. I think that there is now a lot of evidence in ongoing controlled studies that the use of cognitive behavioral therapy coupled with medications has better outcomes with mood disorder in adolescents. Interpersonal psychotherapy, I think that that's where the relationship between the therapist and the patient forms the basis of improvement. I think it's particularly good with severely ill patients who are really motivated to talk about their situation, and with older teenagers who are perhaps, better at abstract thinking, again, are better at that sort of conversation and, personal revelations that are kind of necessary for effective psychotherapy. Family therapy, I alluded to how important family dynamics is, that there are a number of situations where the families themselves need help. They need to be restructured. The parents need some help in redirecting their children, in organizing the household, in getting along better. Single parents who are overwhelmed by the fact that they have to maintain a job, are the sole breadwinners, yet have to provide supervision to 3 or 4 children. Maybe lean too heavily on the oldest child to provide care for other siblings. And these are the kinds of issues that can really have a significant impact on the patient. Pharmacotherapy. Selective serotonin reuptake inhibitors are now sort of the medications that are being used most often in the treatment of depression. Fluoxetine Prozac is the one medication that's been approved by the FDA. There are now a few more that are coming down the line. There have been studies that show that venlafaxine is better than placebo, but only for adolescents. There are a number of open-label studies that demonstrate the effectiveness of bupropion for adolescents with major depression. One of the things that has come about in the 25 years that I've been practicing child psychiatry, I gave a lot of tricyclic antidepressants in the 80s and early 90s, and we've done a number of studies on those medications, and they don't do anything for adolescent depression. So if that's in your armamentarium, I think that the literature has shown that it really does not make a difference for depression. There are a number of side effects among SSRIs and other serotonergic or adrenergic reuptake inhibitors. A number of those side effects are very similar. The side effects tend to be dose dependent, and they tend to be temporary. So if the patient can remain on the medication for several days to a few weeks, a number of those symptoms, a number of those side effects will go away. They tend to be flu-like symptoms, GI complaints, restlessness, diaphoresis, headaches, sometimes akathisia, changes in appetite, sleep problems, sexual dysfunction. Those are the things that we ask about most often with SSRIs. Sometimes you'll get patients who are activated, and they'll present with some impulsivity and irritability. That happens in about 3 to 8% of patients. And you need to differentiate that from hypomania. There are some articles that talk about the fact that if you're dealing with an adolescent with a positive family history of bipolar disorder and you're worried that their irritability is actually part of a bipolar presentation, giving them an antidepressant may complicate their presentation and trigger hypomania. You also want to talk about and be concerned about serotonin syndromes with the use of SSRI. There's some risk. There have been some articles talking about risk of bleeding. So we discontinue SSRIs in the perioperative period. Effexor, venlafaxine, and other noradrenergic reuptake inhibitors may increase blood pressure and heart rate, so we monitor those very closely when we use these meds. Remeron increases appetite, weight, and somnolence. So sometimes I will use Remeron, for example, in patients that have cystic fibrosis and who suffer from depression, because it increases their appetite. They will eat a little bit more, they'll gain some weight, and it helps them sleep. And it doesn't do it in a way that depresses respiration. Trazodone is being used quite often now as a treatment for insomnia. I'm actually a little worried about it. One of the other things I do is I'm a board examiner for child psychiatry, and I don't know if any of you guys are board examiners, but sometimes you see these trends in candidates that come in. And one of the trends right now is to give everybody Trazodone if they can't sleep. I'm a little worried about that because it's hard to know when to stop it. It is pretty effective. I tend to use it, but my recommendation is to use it for time-limited periods and for specific reasons and specific indications. It can also induce priapism in a relatively small percentage of patients. Serotonin is off the market because it causes liver problems. Talked a little bit about Wellbutrin, bupropion. Long-acting preparations are associated with seizures and dosages above 400 milligrams per day. I also want to talk a little bit about SSR and suicidal behavior, because that's gotten a lot of press. You know, there's the black box warning on a lot of these medications. So I just want to briefly talk about that. There's been a meta-analysis by the FDA and by Columbia University. And what they found was that there was a rate of suicidal behaviors, and that includes anything. That includes self-injury, that includes talking about suicide, that includes any kind of ingestion that could be interpreted as self-injurious. And what they found was that there was a rate of 4% on antidepressants versus 2% on placebo. But there were very few suicide attempts, and there were no successful completions of suicide. The concern is that, and the questions are whether the suicidal behavior is due to activation, akathisia, disinhibition, withdrawal side effects due to noncompliance, the induction of hypomania. Wasn't all that clear. One of the analyses that was done in looking at this is a comparison of the number of patients on SSRIs needed to harm versus the number needed to treat. And what they found was that the number on SSRIs, the number needed to harm, was 114 patients on SSRIs. But for treatment of pediatric depression in pediatric patients, the number needed to treat was 9, which means that 14 times more patients will respond favorably to SSRIs than those that will become suicidal. One of the other things that's been interesting is if you look in the data on the rates of suicide, suicide rates had gone down consistently since the 1980s, and they coincided with the introduction of SSRIs. In the last few years, there's been a bit of an increase in the suicide rates. It's not clear whether that's related to the black box warning, but clearly when I talked to pediatricians and primary care clinicians, once that black box warning came out, they were less likely to prescribe antidepressant medications in their practice. How do we use it? The dosages that we use are very similar to those that we use in adults. There's a shorter half-life in kids with sertraline, citalopram, paroxetine, and bupropion SR. We want to monitor for withdrawal symptoms for medications where you give them in a single-day dosage. There are these long-acting preparations that you give once a day, and need to be concerned in some of these patients that they might have some withdrawal symptoms. And sometimes that will present with sort of the same sort of flu-like symptom. You want to keep a patient on medication for at least 4 weeks before you make a determination that the medication actually is not effective. If a patient gives you a history of suicidal behavior, if you have any worries about suicide, they need to be monitored more closely, particularly during the first week of treatment. One of the things about depression and suicidal behavior is that suicidal patients who are depressed, one of the things that keeps them from actually acting out on their suicide is their general lack of energy and anhedonia. And among the first symptoms that are successfully treated by antidepressants is level of energy and anhedonia, not mood. So what happens is they suddenly have the energy and the interest in being suicidal, but the mood symptoms that they had that precipitated the suicidal behavior is still there. When you discontinue the medication, again, you want to monitor for withdrawal, so I gradually discontinue all the SSRIs I use. And you want to make sure that you monitor for medication interactions. How do we prevent recurrent depression? Need to treat for at least 6 to 12 months. Once stable, they should be seen monthly, with consideration given to factors that increase the risk of depression. Some patients require treatment as long as 1 year or longer with monthly or quarterly visits. Patients who do not completely recover, if they don't lose all of their symptoms, are prone to sort of that subsyndromal depression that I talked about earlier and persistent relapse. If patients that have at least 3 depressive episodes should be treated for at least 3 to 5 years with prophylaxis, and that's the current recommendations for adolescents with antidepressant medications. And that's it. So I am certainly interested in any questions or comments that you might have. Yeah?
I thought with a comment, that was an absolutely brilliant talk.
Well, thank you very much. I appreciate that.
I'm a psychiatrist with IHC for 21 years. The question I have, I have several patients that fit, unfortunately, the emblematic bad childhood, anxious, impulsive, dysphoric, irritable. And sometimes I'll come in and say, the only thing that helps me is marijuana. And they're very non-compliant with the treatments that I give them, including follow-up and supportive therapy. And I do believe, a few of these kids I think are honest. I mean, these are, say, 20-year-olds, 18, 20, 21. And like you said earlier on, for them it is anxiolytic. They feel calm. What do I say? I can't prescribe it, but should I tell them they can't get it? What do you think?
Well, the thing that we talk about marijuana, and I've been learning a good bit more about that because we have a chemical dependency program that's part of the child psych program at primary. One of the things right now about marijuana is about 25 times more powerful than it was when we were, at least for me, an old guy, when I was in college. And it's also laced now with all kinds of materials. And so one of the warnings that I give to adolescents when they're using marijuana to treat themselves is that they're actually creating another problem. The other thing is that it really is a gate drug. It really is. It really is that it's the first step in the use of other medications. And so what I talk to parents and what I talk to patients about is that kind of point out that dynamic that they may be treating themselves, and also point out the fact that there are safer and better ways to address that presentation.
Well, that's something that I would say. You never know what you're getting when you're getting a street drug. My feeling about being a gate drug is they're going to do drugs that's an easier drug to get, so I don't know that it's causes the ongoing. But I didn't address the fact that it helps him, and I'm saying I say anyone with a psychiatric problem shouldn't be doing any kind of recreational drugs, which I do believe. So that didn't really answer. I tell them, if it helps them, is there any way we can get it in a better form for these kids? Give them Marinol or something.
Well, I mean, there are no studies looking at this for any, and I think one of the concerns that I also have with this, because I've seen a lot of patients, particularly bipolar patients, do this, is that you can't titrate it. So what begins to happen is that they begin to smoke like all the time. So it's not unusual for patients to gradually escalate that behavior, do it every day, do it multiple times a day.
They're already underperforming, now they underperform even worse.
Yeah, and so it's something, and you just repeatedly point out what they're doing, the relative risks that are involved in it. Also, I mean, you can't treat them psychopharmacologically when they're medicating themselves, and so that's the other issue. The issue is, look, I really want to help you, and there's a range of things. I mean, you can't even do therapy with someone who's intoxicated, obviously, and so there's a range of things we'd like to do for you to help you. But if you're using drugs on a regular basis, recreational drugs, and self-medicating, there's profound limits to how much we can do.
Well, you and I gave rational answers to sometimes irrational kids.
Yeah, right.
One quick thing, but then the facts, you said it's only effective in adolescents. Do you mean not in younger people, or what did you mean by that? Only in adolescents, the venlafaxine.
I mean, I think not in kids.
Okay, that was
only in adolescents. If you're looking at a pediatric population,
okay.
Only in adolescents, not in kids.
In family practice, often the parent brings the teen in. And we're faced with this teenager who's not happy to be there, won't open up, won't talk. The parent's goading you to push them and has maybe called you ahead of time and said, gee, can you do a drug test while they're there? And any thoughts on how we can sort of determine whether is it an over-concerned parent? In some cases, these kids, you talk to them and they really do sound like they're doing okay, and maybe other references to head the parents towards, or ways to sort of sort out that.
Well, I think I talked a little bit about the importance of primary care, and there's what we call the 20-20 rule, that 20% of all kids in any pediatric or family practice have some mental health problems, and only 20% of that group actually gets service. And I think that really the future of child mental health is to enable primary care practitioners like yourself to do a better job with this. And we're working at this. One of the things that we're trying to do is develop instruments that primary care physicians can use on a regular basis that are fairly objective, that can identify these patients as they're coming in. The other thing that we're trying to do is create some networks so that primary care physicians don't feel like they're alone in doing this. And we're also trying to figure out ways of getting reimbursed for these kinds of things. On a more practical level, with that sort of scenario, what I do, because this is what I deal with like all the time in the emergency department and all the time on consultation, because you're dealing with a medically ill patient, they're not there to see psychiatry, so they usually are not real happy to see you. But what I'll do is I'll start the interview with the parent and the child together, and I'll say to the child, you can chime in anytime you like, and you can disagree, you can give a different opinion, and then let the parent talk about what they think the issue is. The thing that happens is you actually learn a lot, not only about that scenario, but you learn a lot about the interaction between the parent and the child. So you get the child who's just sitting there, their heads down, they're kind of like resigned to whatever the parent's kind of saying, and they're obviously frustrated and disheartened by the situation. You'll get other kids who will argue with the parent. Everything they say, they'll make a comment. And sometimes it'll be really biting. And then the parent will make a comment, and they'll go back and forth. And you have a little bit of a window into what's happening with that situation. And you can also, I think, get a sense as to how serious the problem is. Not just based on the stories that they tell you, but that interaction and the data that comes out of it. And sometimes you can even comment on that. You can say, well, now she's saying that, she's saying that she and her boyfriend have a good relationship. You're worried that they don't. So what is it about the relationship that bothers you? And I think that you can sort of fill in the blanks a little bit and also educate yourself as to how serious the situation is.
Thanks.
As a retired thoracic surgeon, I'm now an area medical advisor for the Mormon missionaries. And the Mormon missionaries are, in essence, slightly older adolescents. And we find that many of them have had treatment for depression or had depression in their adolescent pre-missionary days. Some have been on medication and were off for maybe a year. And then they get out on the missions. And some of them get into trouble and some of them don't. Now, do you have any recommendations about these young men or young women that come out and have been under treatment, been on medications and then quit? Should they be started on medications once they come out? And certainly if they've been on medications and are on medications, they need to continue it. But would you give your thoughts on that?
No, I think it's a very good question. I mean, one of the docs, one of our child psychiatrists is Rich Ferry. He's one of the docs on staff at Primary Children's, and he gets involved in this, in the issue of missionaries and previous psychiatric histories in these candidates. And I've talked to him because I've had a couple of patients where this has been an issue. And his recommendation is that it's first of all important to get that history. To get the previous psychiatric history and get a sense of their current status. There's also a mechanism that he utilizes within the Mormon Church where they actually go into the home. There's a process of reviewing these cases. And they're actually, from what Rich tells me, they are very, very good at identifying relative risk factors for that candidate based on current and previous psychiatric risk factors. And so what I'd recommend is first utilizing that service, but also letting the family know that these are really important issues. That the fact that a child has had a mood disorder when he was 16 and he's now 19 and he hasn't had a recurrence, it's an important issue and it should be raised along with all of his other medical history because it is an unusual circumstance. The mission is it's a change. It's a big change. And I think that it's important that both the family address that with the candidate, and that the candidate also address that with their physician and with people that are responsible for that within the church.
Thank you.
I have had two young men whom I have known socially but with whom I did not have any professional relationship, who, as teenagers, became habitual users of marijuana and alcohol together. And then later on, in their mid-20s, one of them sobered up, I guess is the best way to put it. The other one continued. But I noticed in both of them, as they grew older, and they're now in their mid-30s, that they seem to retain a lot of the teenagers' paradigm in life. It was as though they were not maturing emotionally as you would expect them to. I wondered, was this just a rare situation that I encountered, or have you had experiences like this with those who use those together?
We know substance use, I mean, I'm not an expert in chemical dependency, but substance use is a complicated problem, and it can be a sign of other sorts of premorbid psychiatric disorders. There's a strong hereditary component to it. I think that there's also, depending upon the nature of the use and the extent of the use, there can be profound neuropsychological consequences, just really the impact of chronic substance use on the brain. And so when you look at a situation like this, of someone who has been a serious substance abuser for an extended period of time, they stop and there are sequelae of this. There are some problems with this. I mean, it could be any of those things. It could be evidence of a pre-existing psychiatric problem. It could be evidence of the consequences of substance use. It could be, a consequence of their social situation and the way that, I don't even say the way that they've been raised or their family environment. So I think it's important to look at all of those kind of factors.
Okay. Thank you.
Sure. Ah, okay.
Yes. Thank you, Dr. Martini. Yes.